So over to you, sir.
Thank you, Dr. Shilpa, for the kind introduction. And since I have 15 minutes, without wasting time, let me go with the my presentation. And at the outset, I thank Dr. Shilpa, who is doing a wonderful work in infertility, and also my co-speakers, Dr. Chinmay Patki sir, and my good friend Dr. Jay Mehta, who is doing a wonderful work across India in different parts. And uh, nice to be part of the team and with you all to share my little bit knowledge on infertility, which is basic topic on HSC. Why I chose HSC as a topic is it's very basic topic, but then most often underrepresented or underdone or less represented, I should feel. So not many people use it thoroughly, nor many people are going to kind of read it well. We presume that radiologist has done and we read his report. But if you go deep, you see a lot of things which are important and you will know that, oh, so many things are there. So these are the few indications and contraindications. I don't want to waste too much time in the basics, rather than I'll show you more pictures of how to identify and different pictures. And these are the basic instruments that are used. And these are the catheters and equipments used. This is a normal HSC, how it should look, a triangular contrast film with a nice tubal spill. Why they should take 4 spot films together is because initially sometimes you'll not be able to see this, the defect, the filling defects and the other things. So it's early filling phase, the uterine distinguishing phase, and tubal filling phase, and then peritoneal spillage. If you take only one in this, you might be misguided, and you may feel this second is a tubal block, or this you can feel that is not its spill, so left tubal block. Wrong report is possible. So these are the different detectable pathologies that you are able to see in case of an HSC, uterine anomaly, fibroid, adenomasis, polyp, etc., adhesions, etc. And you can see a air bubble also, or myometrial folds and glands. So these are the different filling defects. You can see air bubbles, folds, synechia. See, can you see the air bubble here in this HSC? This is a typical air bubble, which is spot radiograph can easily identify. So it could be a filling defect also. The importance of taking 4 different images is you can see the filling defects here in the first film, which is persisting here, but it disappears in the next film. So that's the importance of taking 4 films. If a small pathology is there, like a small fibroid or polyp, you may see a filling defect. But if in case you are seeing another film, it has disappeared because it's an air bubble. It's the importance of taking multiple films. You can see a normal physiological uterine folds in wherein the parallel aisles run, or you can see prominent cervical glands, which are most commonly you will see it. You must have wondered what is this. These are the cervical glands that you see. And this is a C-section scar or isthmocele. What you see in most of these previous LSCS patients when they do a HSC, you'll be able to appreciate isthmocele or a LSCS scar. Whereas uterine anomalies can be identified by doing simple HSC. Like one of the most common identifiable pathology is unicornate uterus, wherein you will see one cornua with one tube, or you can see a uterine didelphys anomaly, wherein they can see it separately splayed uterine horn with a deep angle, or you'll see a bicornuate unicollis uterus, or you can see bicornuate bicollis uterus, wherein completely 2 different, you can see the arrows. So both are, you can see. And bicornuate uterus, the angle between the 2 uterine horns, if you see, it is more than 110 degrees. You can see the different completely splayed horns. And this is another image of a diethyl sylvestrol related abnormality, which was prominent earlier, and now you don't see it so prominently. And this is the arcuate uterus, and which is commonly seen. This is a nice septate uterus. The angle is less than 75 degrees. That is acute angle. So you can see a lot of infertility cases wherein if you do a hysteroscope, you will be able to see a lot of septate uterus. And septate uterus forms an acute angle that has to remember. The difference between bicornuate and septate is it's a fundus indentation, wide cavity in case of widely separated cavity in case of bicornuate uterus, wherein in septate it is a less cavity. So angle of 75 degree between the 2 uterine horns is of a septate uterus, and more than 105 consistent with the bicornuate uterus. So this is a septate uterus again. This again could be a septate or bicornuate because the angle is between 75 to 110. Again, a bicornuate uterus because you can see a widely splayed horn above 105 degrees. This is a classification criteria for differentiation of septate from bicornuate uterus, wherein you can see the apex joining the line, wherein if you see the ostia in the same line, or the cavity which is above the line or below the line. Based on that, the apex is more than 5 millimeter or below the 5 millimeter. Accordingly, you can classify it to be a septate or a bicornuate uterus. So this is again an ultrasound examination. You'll be able to make out again a bicornuate or a septate uterus. And see, sometimes the septate uterus, but then it appears as a bicornuate, sometimes in HSG. In such cases, the 3D ultrasound will help you to differentiate, and 3D ultrasound is a good tool. Again, this is the histoscopic view of a partial septum, and it's a broad fundus with the septum. So this is a complete septum and a partial septum. So partial septum is more common than the complete septum if you are doing infertility practice. You'll see a lot of partial septum, which sometimes may not require excision, but then in case of infertility or miscarriage history, you might need partial septum resection. So this is a complete septal resection. It is being done. It's preferred to use a scissor in case of septum because the electric source might cause some kind of injury and subsequent adhesions. You can see even the adenomyosis you can identify doing a simple HSG. You can see the crypts inside the adenomyotic crypts are there in HSC. So even a simple HSC can diagnose a complicated disease like adenomyosis. So irregular outline with multiple diverticula. You can see the extension that's in adenomyotic uterus. You can see filling defects in the HSC. These filling defects here and filling defects here are suggestive of the fibroid uterus. So there are multiple filling defects you will see in case of fibroid uterus. This is again a fibroid. You can see the arrow mark here. This right submucosal myoma you can see. And another is salpingitis isthmic nodosa. It's an outpushing of the isthmus on one side, other side. You can see small outpoachings here in the fallopian tube. These are the SIN or salpingitic isthmic nodosa. Sometimes it's seen in the tuberculosis patients, very common. You can see SIN here, as 1, 2, 3 dots like beads, and hydrosalpinx here. So generally seen in the tuberculosis cases. And this is a hydrosalpinx. You can see here a big hydrosalpinx, which is one of the common findings. We should be able to identify hydrosalpinx like these very well in the HSG. And this is a tubal polyp. So you can see a small filling defect inside the beginning of the cornua. That is a polyp here. This tubal polyp. And again, a tubal polyp, can you see a filling defect here in the proximal part of the fallopian tube? This is a tubal polyp. Again, this is a hydrosalpinx, which is one of the most important factors. So the basic idea is you should be able to read HSC yourself and identify these diseases. And this is case of peritubal adhesions. You see now there is a spill here, but unfortunately you can see the spill is completely localized. It's not able to trickle down. So it means that it's a localized adhesions are there around the peritubal adhesion. So this is very important to make out peritubal adhesions, and once you make out, it will be easier to handle. Again, you see a peritubal adhesions here. The tubes are stuck. Even the spill is here. It's not able to even come down. So it is a peritubal adhesions with the localized spill. So Seneca are kinds of uterine adhesions which can happen after tuberculosis or repeated curettage or infection. They cause a lot of filling defects. You can see almost moth-eaten like uterus. Half of the uterus is eaten in irregular outline. You can see the irregular outline. All these are suggestive of the kind of Seneca. These are all different histoscopic view of such Seneca which needs to be corrected by doing a hysteroscopy. And this is again, you see a central filling defects here. Again, this is the Seneca here. Again, you can see the defects here, filling defects. All these are different Seneca. So these are the patients wherein they need a hysteroscopic correction if possible. And again, subsequently, they need a healing process. So these are intrauterine adhesions, and it could be cervical adhesions also, and they need to be cut well. And this is a corneal spasm. It's difficult to make out sometimes with a tubal block, but sometimes when there is spill on the other side, you can make out a tubal. This is again a corneal block. This is intravasation is important because if the tubes are blocked, if you can see this, this is a nice intravasation. You can see the vascular anatomy. This looks more like an angiogram than HSG. You can see so much of the nice vascular delineation in this HSC because of such a severe block. The vessel, the dye enters into the veins, and you will see a vascular intravasation. And you see this is lymphatic intravasation. Can you see the small spider web-like appearance? These are all lymphatic intravasation of the dye. And then along with that, you can see the vascular intravasation here. Because of the block, so you can see the vascular as well, the venous as well as a lymphatic intravasation in this. And in case of tuberculosis, there are some specific findings like beaded tuberculosis, beaded tube, golf tube, pipe stem tube, cobblestone, leopard skin, so etc. These are the different HSCs. Sometimes a tuberculosis disease may not be identified in the person, but HSC will tell you that there could be a past history of the tuberculosis. So you need to keep these different things in mind. You can see this is a tufted tube. So multiple small diverticular-like appearances surrounding this ampulla, which are produced by caseous ulceration, which gives our tubal outline a rosette-like appearance. So this is called as a tufted tube. Again, I told you SIN, that is salpingitis systemic nodosa, wherein you can see these small tubal outpoachings here and here. So all these are tuberculosis features. And this is a cotton wool plug. So when the contrast medium is injected, it is distributed like a small cotton reticular pattern, which looks like a cotton plug. So that's why it's called as a cotton wool plug. It's again one of the characteristic feature of a tuberculosis. You must have seen many HCCs like this, but yes, these are the ones which are defining. And you can see the beaded tube. The small multiple constrictions along the fallopian tube gives rise to a beaded appearance. And these beaded appearance are again a classical example of a tuberculosis, wherein you can see the beaded. And here, this is a golf club tube. So I've shown the example here. So this golf club tube is a circulation of the both tubes in the distal portion, wherein hydrosalpinx is there. So it's not the spill is not happening, but it is distending into a golf club pattern. So that's why it's called as a golf club tube. This is again a pipe stem appearance. So if you see in old textbook of Datta, also it is mentioned a pipe stem, the lead pipe appearance. So these are the few. You can see the light, the pipe stem here, the old cigar pipe stem. So this is how a tuberculosis looks because of fibrotic changes which have happened in the tubes, as well as you can see the uterine contour is completely distorted because of the tuberculosis. Again, the floral appearance. Floral is flower. So there is no flower here, but you can see that the dye is taken place in the form of a flower. That's why it's called as a floral appearance. And this is a leopard skin. You can see the air. You can see the air in between the in the fallopian tube along with the mass. So this is kind of, it gives a kind of leopard skin appearance because of multiple rounded filling defects with the intraluminal granuloma formation in the hydrosalpinx. That's why it's called as a leopard skin appearance. And this is a cobblestone appearance. Can you see the stones like structures here, cobblestones like pebbles here? Again, one more feature of a tuberculosis. You can see here again there is a localized spill with adhesion, peritubal adhesions on the right and cobblestone on the left. So this is a intraluminal adhesions. It shows intraluminal and periluminal adhesions. The lipid tube. You can see this complete tube is gone up like this and it is adherent up. So this is another example. This is also called as corkscrew. I have put a picture here for a corkscrew so that it's easier to resemble. Can you see the corkscrew appearance pattern here? So this is a dense connective tissue causes the lack of tubal mobility. So it is completely gone and stuck, like as if the hands are stuck up. So this is why it's called as a corkscrew appearance. And this is a peritubal hollow. How you see the hollow behind the head of the illuminated pictures of Buddha or anything. So like that, you can see here peritubal hollows here. Peritubal hollows are the ones which suggest there could be possibility of peritubal adhesions. And it's a tobacco pouch appearance. Again, you see in the textbook of Datta, it's a terminal hydrosalpinx, which will give rise to a tobacco pouch appearance. And this is again terminal circulations, which is seen. Can you see the terminal circulations here? And then again, can you see the extensive synechiae? Uterus is completely distorted here. You see intrauterine adhesion and distortion. And this is actually a uterus. It's a pseudo-unicornate uterus because completely it is adherent and there is lot of intrauterine synechiae. This is a proper true unicornate uterus, but then this is pseudo-unicornate because of the intrauterine adhesions. It is giving rise to appearance of unicornate, which is not. So this is a T-shaped tuberculosis uterus, where you can hardly see any cavity here. You can see the T-shaped tuberculosis uterus completely obliterated by intrauterine adhesions. And this is called as trifoliate. It's like a bilopatra. Like you can see a 3 leaves pattern, 1, 2, 3 leaves. Because of the multiple adhesions and distortion of the uterine cavity, this trifoliate shaped uterus is because of the synechiae or the intrauterine adhesions. You will see, and it will look like a these are different hysteroscopic views of such HSGs, where you will see a lot of adhesions, lot of calcifications are there, and different tubercles also you can see tubercles, calcification, and other abnormalities in this. So this is HSG is one of the minimally invasive and one of the best modalities. And I think I just did in 15 minutes. Thank you again, Dr. Shilpa, for the opportunity, and KSOGA for me having me.
Yeah. So thank you, sir. It was wonderful. I think nowadays we see more of laparoscopic photos and videos, and HSGs are, I think, considered very basic, but I think it adds a lot of value to the infertility workup, and it gives us an insight as to what is the tubal factor. So this was excellent. So I welcome Dr. Chinmay Patki, our next speaker. Sir has just received a silver button from YouTube for having 100K subscribers, and Sir is a champion in digital marketing, and his work also, like I think, is one of the busiest in India, or probably like yeah, in India. And Sir has immense experience because he does so many cases, and his volume of cases that he deals with is quite tremendous. And he's a very, very, very humble human being who is always so helpful for all the youngsters. If you need any help regarding setting up practice, or you're setting up Google business page, or even like YouTube channel, Sir is always very forthcoming to help youngsters out there. So, sir, I think this topic has to be spoken because it is one of the most abused and underused tests, I can say. So, sir will be talking on enigma of endometrial receptivity and ERA test today. So, over to you, sir.
Thank you, madam. Before I begin the topic, let me tell you that it's a huge honor to get invitation from our great Shilpa madam. And I have a very good association with Karnataka because not many know, but the fact is to prepare for my MD exam, I stayed in Bangalore for 2 years, and I was working in Jaideva Institute of Cardiology for 2 years.
Oh.
So I used to stay in Jayanagar, and Bangalore is extremely dear to me. And more than that, my grandmother is from Karnataka. My wife is from Karnataka. I'm half Kannadiga. So I don't feel like an outsider when I get invitation from Karnataka Society. So let me start. This is the first invitation from Karnataka Society, and I'll try my best to make sure that the session is going to be a very inspiring one. So let's talk about enigma of endometrial receptivity and ERA test. Now remember, as and when in last 15 years, what I've seen is the moment you start getting good number of cycles, the moment your practice starts increasing, slowly your sensitivity towards those negative IVF cycle actually comes down. After a point, you don't feel like much of a loss. If you see a patient, अरे चल ये negative आया वो negative आया, you don't feel much. Slowly you start losing that sensitivity because simply the volume you are doing is so tremendous that you end up seeing positive cases every day, and because of that you develop a bias where you start feeling that whatever you are doing is not next to God but above God, and you know everything. And then that is how we start dealing with patients. Patients go on doing multiple cycles, And yet, I have seen that in last 2 decades of my practice, we are still not ready to accept the newer evidence the way we should. And whenever the test comes, either we classify it as useless or we classify it as high. But there are some tests which actually talk substance. Now, let me begin with the endometrial receptivity. Remember, when I started doing this, I'm doing this for last 7 years. I've done more than 500 patients of endometrial receptivity. So I can definitely say that I know a thing or two about it. But I started as an arrogant man. When ERA came, uh, it used to cost 65,000 rupees, if you remember, all of you, way back in 2015, 2016. And that time I used to hate this test. I used to think, iska kya zarurat? And with the same mindset, when I went to Barcelona for one of the ESHRE, there I met the great Carlos Gomez. And in the same vein, I asked him that the one who invented about this test. And I just asked him that, sir, what is your opinion about your own product? And I was expecting a long commercial speech. Instead of that, he just told me, my dear, I have done only 30,000 cases. If you feel that it is useless, please use it for a few patients. And if you feel it's not useful, please throw it away. I'm not going to convince you. That was very humbling experience from a man who has done such a huge work about endometrial receptivity. That is when I came back to India, and then I started doing tests. And slowly I realized that the reason in India endometrial receptivity analysis is not picking up is not because we are not open to it. It is one of the reasons. But primarily the reason is our protocols needs to be different than the European protocols. What happens is, along with endometrial receptivity, that kit, whatever comes with that, the information, we tend to follow that information. And you will find that even if you are doing those tests sincerely, either most of the tests will come normal, or even if they come abnormal, and if you follow that protocol, your patient will not come negative, will not come positive. And that is where you will start feeling this endometrial receptivity is not working. That is why I'm going to also talk about the personalized ERA test, where how we Indians should do it and not follow the Western approaches of doing this test. So let's begin with this. Now, whenever we talk about endometrial receptivity, we have to remember that, just a second, I think I'm stuck. Yeah. Whenever a patient walks into the IVF clinic and they undergo few cycles, this is the sentence they get to hear. Your uterus is not accepting the embryo. Now, can we all put our hand on our heart and talk about this cavity? How much or how little do we know about this cavity, which can actually make a human being? Imagine, just for a moment, forget about the fact that we all are IVF practitioners. And just imagine a human being is creating another human being in their own body. Now, a nature which has started developing from a single cell to amoeba to a multicellular to a complex human being, this reproduction process is extremely complex. And all we know is giving 5 days of progesterone and expecting that our cycle should work. It is not how it happens. And that is why talking about endometrial receptivity is extremely important. What is endometrial receptivity? Endometrial receptivity, now every word is important. I want you to remember this. Endometrial receptivity is a self-limited period during which endometrium transiently transforms. Now, it is not a permanent transformation. It transiently transforms to acquire the ability to receive blastocysts and support implantation. That is, in gist, what is endometrial receptivity for you. Now, whenever we talk about endometrial receptivity, we have to remember that each month, whenever the periods are happening, after that, what remains is basal layer. And this basal layer has ability to regenerate and respond to ovarian steroids. And that is how our treatments are working. That is how the endometrium actually becomes receptive. But when we talk about this receptive endometrium, we have to understand that, whenever we talk about endometrial basal layer, we have to understand that this endometrial basal layer has ability to regenerate, and it has also ability to respond to ovarian steroids. Now, a receptive endometrium and a functionally normal blastocyst, as well as a coordinated cross communication between them, are required for implantation. The process by which embryo attaches and invades the underlying maternal endometrial tissue. Now I want to talk about this slide. Now remember, when we talk about embryo, we have actually grown from a day 2 embryo transfer practice to day 3 embryo transfer practice to day 5 embryo transfer practice. Now we are also talking about PGT embryos, euploid embryos. Then we also talk about laser assisted hatching. Then we also talk about high lays. We talk about everything which is rotating around the embryo, and we are only talking about embryo. But the endometrium per se, we are stuck about 120 to 130 hours of exposure of progesterone, and that is where we will transfer the embryo. Essentially, we have done everything in our capacity to talk about embryo, but we don't talk about endometrium. Why? Because our underlying belief that the endometrial receptivity is fixed for everybody is not changing. And today's presentation will help you break that barrier. Now, during window of implantation, the endometrium acquires the receptive phenotype, which involves both morphological and molecular changes. Now, what we see on sonography is morphological changes. That is why after giving progesterone, after giving estrogen, we are checking the endometrial thing. But what about molecular changes? We are not aware about molecular changes. We just check progesterone levels, we check estrogen levels, we check endometrial thickness, we check blood flow. And that is how we indirectly come to a conclusion that probably this endometrium is receptive. But when we talk about a receptive endometrium, it's not just morphological, but also molecular changes. Now, this transient period, which is called as a window of implantation, it has been postulated to remain open for 5 days after endogenous or exogenous progesterone action and close to 2 days later. Now, the biggest confusion all of us have is the natural implantation vis-a-vis IVF implantation. Remember, when we talk about natural implantation, we really don't know for how much time the natural implantation window remains open. But when it comes to IVF, we have a very rigid protocol where we only give 120 to 122 hours of progesterone and then we do the transfer. Now, in this transfer, we have to understand that there is one party that is endometrium and another which is embryo. And there is a crosstalk in between them. The endometrium and embryo, they both speak to each other. The physiological process, this physiological process represents first embryo-maternal, bidirectional, synchronized communication followed by adhesion and subsequent invasion of decidualized uterine stroma. Now just look at this wording, how beautiful it is. This is the first a bidirectional communication between mother and baby, a future baby. So obviously both parties are talking. And in that, the window of implantation plays a critical role in establishing this bidirectional communication. It's like I'm talking to you right now. One of us is endometrium, one of us is embryo. But what if internet goes down? Even if we both are online, we assume that you are there and I'm here. Still, we will not be able to establish the dialogue. That is the beauty of window of implantation. Now, what is this crosstalk? So human pre-implantation embryos have the ability to exert a phenotypical changes in endometrium. At the same time, a human endometrium is aware of the embryo, modulating the response of local immune response to the embryo specific factors. Now look how sometimes we miss the obvious thing. Whenever we are explaining to the patient about transfer of day 2 or day 3 embryos, we often tell them that embryo quality perhaps is not good and the uterus will be able to help your embryo. What do we mean by that? We are telling them that perhaps uterus is a better incubator. But does it limit to that? It doesn't, because we know that endometrium has the ability to repair, to bring out certain changes in embryo, even if we see a lot of fragmentation in them. And we all have seen many such cases. At the same time, you have to understand that a good embryo also has the ability to make a nice endometrium. I'll give you an example. Many a times, all of us in our practice, we have transferred those embryos into those 6.57 mm cavities, right? At the time of transferring the embryos, we are constantly nervous. Kya hoga? What will happen? After transferring embryos, if some of you have checked on sonography, after 5-6 days, suddenly you will start seeing a beautiful endometrium. Now, what's changing there? It is the embryo which has exerted the influence on the endometrium, just like the endometrium also influences the embryo. So clearly, this is a bidirectional communication, in which today we are going to talk about the endometrium part. Now, what do we need to know about endometrial receptivity? So the first thing we need to know about is endometrial dysfunction vis-a-vis endometrial desynchronization. These are two different things. A beautiful presentation before me in some way talked about endometrial dysfunction. If you have endometritis, if you have septums, if you have polyps, if you have adhesions, then it leads to dysfunction of the endometrium. It doesn't lead to desynchronization, although it does in few cases. But when we see a beautiful young lady with good endometrium, and even in there, when we don't see the implantation, it is not a case of endometrial dysfunction. It is a case of endometrial desynchronization. Whenever the IVF cycle fails, the first thing we advise them is let's do the hysteroscopy to rule out the infection, to rule out the polyp, to rule out the septum, to rule out chronic endometriosis, and so many other things. That essentially means we are addressing endometrial dysfunction. We are not addressing endometrial desynchronization. So after doing hysteroscopy, you will get to know about dysfunction, but what about desynchronization? And for that, measuring endometrial receptivity is also equally important. We all in our basic OBGY, training, we have seen this dating of endometrial biopsy, a report which goes back, decades. Now that man in 30s, 40s, and 50s talked about how endometrium changes its layers between early follicular phase, late follicular phase, luteal phase, how the endometrial biopsy will show different morphological patterns. But what have we learned from it? When we talk about endometrium, we are stuck about the receptivity window, which is 5 days, even though we know that endometrial morphology does change progesterone. So how do we actually find out the endometrial receptivity? So there are various tests like transcriptomics, proteomics, secretomics, and lipidomics. Now, all of this is ever evolving and ever developing. Today's topic is about transcriptomics of endometrial receptivity. Let's begin with that. What is transcriptomics? Transcriptomics, it reflects that genes that are actively expressed at any given time in a specific cell population of the tissue. We all know now that certain genes, they get activated at certain times. So for endometrial receptivity, there are close to 238 genes which actually get actively expressed only during implantation. Have we ever thought that why a lady only during a certain period only conceives? On one side, we are advising patient to have intercourse after ovulation. That means we know something is changing at the endometrial level, right? Apart from just egg. So what is changing is basically endometrium is not only changing its morphological structure, but it is also actively changing its genetic structure. And this is the key word, that transcriptomics, it reflects that genes that are actively expressed at any given time in a specific cell population of the tissue. Now, during implantation, what happens is a transcriptional gene awakening. Means those genes, they temporarily get awakened, they perform their task, and they go back to the sleep. If during that time they get embryo, fine, that is when they perform. The process is regulated increase in serum progesterone window of implantation. Now, when we administer progesterone, many of us in our practice, we do check what is the serum progesterone level. Why? Right? Why do we check serum progesterone level? Some people put criteria of less than 10, some put it below 30, some put it below whatever it may be. But point is, we want to measure that progesterone. And when that serum progesterone level is less, we infer that probably endometrium is not ready. What do we mean by that? It essentially means that this progesterone actually causes something to change in the endometrium apart from just endometrial thickness. Because if progesterone had only one function of increasing endometrial thickness, then how are we seeing pregnancies in thin endometrium also? So that means progesterone is not just changing the morphological structure of the endometrium, it is also changing its phenotype. It also actively expressing the genes. And that is how, even if endometrial thickness is not good, many a times we do find these patients conceiving. And this is the reason behind it, that perhaps at that time, even if their morphological structure is not good, their genetic expression is good. And that is what explains how thin endometrium patients actually conceive. Now, let's understand this endometrial receptivity. So endometrial receptivity, basically the analysis involves analysis where energy signatures are coming from. When we talk about endometrial receptivity, it is a tool which is actually picking up those signatures of the gene. So what they are doing is they are trying to find out, are this does this endometrial sample matching the endometrial signatures which they should after adding the progesterone. Here there is no talk about endometrial thickness. We are only talking about endometrial receptivity. Now, which are the candidates for endometrial receptivity analysis? Now, after doing 500 tests, these are the criteria which I will advise all of you where you should do endometrial receptivity. The first is extremes of age group. All of us have those young 25, 26-year-old girls, patients who have come to us for IVF, where we were all super confident that patient will conceive in first cycle. And there, nature has made us cry like anything, where a lady has not conceived for 2 attempts, 3 attempts. All of you will agree that we all have seen such patients. Similarly, a patient who is over 40 years, we tell them that you have an implantation rate of 10 or 15%. What is the reason this implantation rate is less? One of the reasons is also their receptivity is different. The second group, which I have seen very commonly in my practice, is grade 4 endometriosis patients. You will often find in these patients the endometrial implantation window is displaced. Third, an extremely relevant topic for today is patients with premature ovarian insufficiency or premature ovarian failure. If you are having young patients with 25, 27 years old with AMH of 0.5, 0.6, please do their endometrial receptivity analysis because you will find that in many patients there is displacement. Obviously, the next indication is recurrent failed IVF. Now, fifth indication will surprise you. Why in recurrent abortions do we need endometrial receptivity? So you have to understand endometrial receptivity is a spectrum. Imagine your endometrium is expressing certain genes which are at their prime at midpoint, but they also have extremes of end. So when the embryo gets implanted at one end, which is too early, what you see is failed IVF cycle. When the embryo gets implanted at the second extreme, where the expression has happened, but now it has weaned off, now it is so poor that even if endometrium is receptive and embryo does get implanted, it does not find a good energy from those upregulated genes, which explains many a times there is a recurrent pregnancy loss. That is why in patients with recurrent abortions, do check for their receptivity. The last is scarred uterus, wherein if you have multiple surgery history, myomectomy, adenomyomectomy, septum dissection, and if you are not going to find a positive cycle, then perhaps you should consider doing this. Now, how do you do endometrial receptivity analysis? After doing close to 500 cycles, I'll recommend all of you that even if they tell you to do HRT cycles, natural cycles, please don't do endometrial receptivity with natural cycles. You will find a lot of problems with natural cycle protocol because it is very difficult to mimic one cycle vis-a-vis another. If you are going to be doing a natural cycle, it is very important to notice all those estrogen, LH, progesterone levels and mimic them exactly in the next cycle. I always strongly use HRT cycles. Now, if they are down-regulated cycles, fine. If they are not down-regulated cycles, even that is fine. But make sure that you do not develop follicle when you are doing endometrial receptivity because it will not work very properly in your subsequent cycles when you want to do transfer. Now, I'm going to talk about important points where you should pay attention. See, all of us, we know how to do ERA tests, but there are certain things which I would like to share with you. Number one is about protocol, what protocol changes. Second is procedure. Third is storage. Fourth is transport. And fifth is interpretation. Now in protocol, what I would like to tell you is endometrial preparation. Now what happens is many a times those booklets which you get along with those kits, they will tell you give 6 mg of estrogen, give it for 8-9 days, check for endometrial thickness. If it is 7.5, then add progesterone. That progesterone tablet is utrogesterone 200 capsule twice a day. Then you follow that. After 5 days, you do the receptivity. You get a nice personalized receptive report. Then in the next cycle, when you are having to transfer the endometrium, now you are in fix. That will this low progesterone be enough for my patient? Now the point is, giving that vaginal progesterone is not a problem. But our Indian patients, a lot of patients are having vaginitis and the absorption is not proper. So do not hesitate in using your endometrial preparation exactly like you are going to do your embryo transfer protocol. If you're a person who puts vaginal gel, who gives oral progesterone or even intramuscular progesterone, do not shy away from using the same protocol for doing endometrial receptivity, and you will find huge change in your results. Problem what happens is when these companies we follow their protocol, if you check their progesterone levels at the time of receptivity, they are very poor. And this type of protocol does not suit our patient. That is the problem, and that is why these protocols, these tests are going into disrepute. We have to use our progesterone protocol and use ERA accordingly. The second, I always insist is whenever you are doing endometrial receptivity, please ensure three things. On whenever you are going to add progesterone, make sure that you will check your serum progesterone level. It has to be less than 1. Even if it is 1.1, please do not add progesterone. You will have to cancel that cycle. The second and extremely important is, I have seen in my earlier times when I used to do ERA, when it doesn't never used to match the results, I have developed a protocol where we also do an independent Doppler evaluation. Now it is like I am not going to do ERA. I am going to prepare the endometrium where I want at the time of transfer, at the time of addition of progesterone, I want that the endometrial, the color Doppler value should be in range. I want the uterine artery PI should be at least less than 3.5, preferably if it is less than 3. I want it. So in such cases, when you do that, you also check for Doppler flow when you see it in all across zones. And that is the time when you also check your serum progesterone. And then you add progesterone. That is how you are actually doing your embryo transfer. Now, where do I recommend doing receptivity? Is exactly in these cycles where you have done all the work and still your previous cycles fail. In such cases, using the same protocol, you try giving that endometrium for analysis, and you will find that perhaps these patients are having displacement of implantation. I've already covered progesterone administration. Like, don't shy away from using the same progesterone protocol which you had used for that patient during the last transfer. Only then patient will also understand that, okay, my doctor had given this protocol. Now they are checking that whether my actually endometrium is receptive or not. Otherwise, what happens? At the time of your transfer, the protocols are different. At the time of receptivity, your protocols are different. You yourself will not understand, neither will patient. So keeping the same protocol is very, very vital. Now let's talk about interpretation. Now these interpretations, they will often confuse everyone. So I'll give you a nice analogy. Imagine a train station where you are standing and the train is coming. Okay? The train which has arrived exactly at a point where you are standing is the perfect spot, that is receptive endometrium. Or endometrium which is receptive, it is again divided into 3 points: optimally receptive, early receptive, and late receptive. You will often find many new companies are actually not giving reports accordingly, but this is how it should be reported. Or optimal receptive profile, which will indicate optimally receptive endometrium, means train has just arrived at a spot you are standing. While the early receptive is where you are standing there, but it has just entered the station. It has not arrived at your spot. So probably there, additional 12 hours of progesterone will do the trick. In our practice, we do give, if the 120, 122 hours doesn't work, what we do is we add the overnight progesterone in the next cycle. We give them 12 hours extra. And there the sometimes cycle work. Why they work? Because perhaps this patient was having early receptive profile. Similarly, a late receptive profile where you are standing somewhere and the train has actually passed. There you have to give 12 hours less progesterone. Now giving less progesterone really psychs us. We cannot accept that patient can require less than 120 hours of progesterone. And that is where I'm going to show you some interesting factors. Now, this is non-receptive endometrium. I've seen quite a few cases of non-receptive endometrium where the adequate receptivity has not yet occurred. Now, you feel that you have given 5 days of progesterone, but when you do biopsy, it will tell you that either it is pre-receptive or post-receptive. Now, these are the cases where actually endometrial receptivity will help you immensely in making sure that your patients conceive in subsequent cycles. So, if you are having a personalized embryo transfer protocol, divide it into early receptive, optimally receptive, and late receptive. If it is receptive transfer, if it is early or late, give just 12 hours ka difference and the trick will work. But if you are pre-receptive or post-receptive, there you will even have to repeat your biopsy. And that is where the main problem lies in our country, that companies will charge again because they have given. So whenever you are giving the samples, make sure that you are having arrangement with the company where you will insist that your patient will not pay again. That is how you can deal with them and insist that they will have to do one more biopsy, and perhaps that will help you in knowing exactly the time where you are supposed to do the transfer. Now, why should I do it? This is the question. Let me show you a few humbling slides. I'm sharing the experience of just 300 ERA tests, my initial, because now we do it for very, very specific patients. This was one of my first patients. Look at the HRT. To perform blastocyst transfer at 100 plus 3 hours of progesterone administration. I was always taught that you have to give 5 days of progesterone. This girl, her name was Mugdha. She was 26-year-old, MBA. She walked into my clinic. I was super confident that she will conceive in one cycle. She had blocked tubes. We gave her antibiotics, started her on IVF. I took 3 attempts and none of the attempts worked. And that is where I felt, okay, let me start with her receptivity. And this is the report came. After this, the subsequent report of another patient, I'm not sharing that slide, was 96 hours. The least I have seen is 92 hours. That means giving just 3.5 to early 4 days of progesterone is enough to accept the blastocyst. We always give more days of progesterone than the age of embryo, right? Here, you have to give just 4 days of progesterone for a 5 days embryo. And that is where the trick works. This is a pre-receptive. Again, this patient is having 146 hours. Now you are giving 5 days progesterone. This patient requires 7 days progesterone. I have also seen the maximum implantation window of 178 hours, where patient required 7 plus days of progesterone to accept a blastocyst, which was 5 days blastocyst. And all those slides which I'm sharing with you, those patients have shown us pregnancy. They have delivered full term. So none of these tests are just like I'm showing, are just reports आया है लेकिन बाद में pregnancy report नहीं हुआ. None of them are like that. Let me show you simple chart. Now, if you look at it, here the receptivity is the blue color. You get around 36 patients receptive. What do we always tell our patient? Success rate of IVF is 30 to 40%, right? That is where you get 30 to 40%. Rest are pre-receptive, post-receptive, early and late receptive. Now we have to understand that when we talk about success rate of IVF, it just doesn't revolve around embryo. It also revolves around endometrium. So when patient is not conceiving after transferring good quality blastocyst, we have to not just look at PGT, but we also have to look at endometrium. Let me show you age-wise distribution. This is the age considered most dangerous. 20 to 25-year-old girl. Now we all are getting those young patients as well from a very traditional background where they want to go for IVF if their tubes are blocked. Or we are seeing a lot of patients with low sperm count, oligospermia, where IVF is necessary even in these young age. And there you will find a lot of young women will have this receptivity problem. You will always find young women having abortions, right? All of us have seen 18, 19 years patient, they come with abortion. Then we tell them, कुछ मत करो, 2 साल शादी हुआ है, अभी 2 साल कुछ मत करो, बाद में सब ठीक हो जाएगा. What is changing? Their endometrial receptivity is changing. That is the time when it was too early to receive those embryos, and that is where they are aborted. So, lot of conversation we tend to have with patients, no? This conversation actually revolves around endometrial receptivity. We just don't realize that we are talking about endometrial receptivity. Look at this age group, where you will see 35% patients with receptive and 35% patients pre-receptive. The maximum patients are of ours fall in between this 30, 26 to 35 age. That is where it convinces us that we don't need ERA. Why we don't need ERA? Because some cycles they conceive. If they don't, we just add overnight progesterone and then they conceive. And that is where we are confident that now we don't require analysis, because majority of our patients are conceiving. But what about those patients who are not conceiving? Because they also represent 28%, where their endometrium was not receptive. So if you have 2 failed cycles, if you have done good transfers, If everything is correct, then do consider about endometrial receptivity. Now look at this chart, 31 to 35 years. Again, you will find many patients, close to 30% patients who are not receptive. And that is how we are sure about that 40%, but we don't look at the endometrial receptivity. Look at this. The moment 36 to 40% happens, you will see the rest of the figures increasing, where close to 50, close to 60% patients are now in not non-receptive window. That is how our IVF results actually start dropping. Look at this, 41 to 45. Again, you will see most of the patients will have displaced implantation window. So I would just like to share with you with this data. I would just like to share my thoughts that if you are confident about it, even then, please be curious. Don't be judgmental about endometrium. Please be open about these new things and start doing endometrial receptivity tests for at least certain group of patients where you are confident that rest everything was normal. I thank you for your time. I hope it was fruitful discussion.
Yeah, it was an excellent discussion, sir. Thank you very much. So I think there are a couple of companies that offer the ERA test. So are all the companies doing the same gene analysis, sir, or they have varied genes that they will be testing and offering the test?
So let me tell you the biggest and most important thing. The company we started, the Carlos Gomez, the Igenomics started.
Yeah.
The only lab of Igenomics is situated in Valencia. Whether the samples are collected in India, Asia, US, or any other continent, all these samples, they go to only one lab, that is Valencia. See, they have a patented product. They have not shared their genetic profile data with anybody. What others have done is have drawn from this data and they have actually started doing genetic analysis of the endometrium, where they have figured out that in this receptive endometrium, these are the metallosomic or transcriptomic signatures we have to pick up. And that is how they have developed their product. Now, in their product, the problem which I have seen earlier is they never used to talk about hours. They used to talk about receptive, pre-receptive, or post-receptive. If you remember, what started happening is when clinical practitioners in India, they started demanding number of hours because the other company was giving, they started putting figures also on it. But I highly doubt the authenticity of these figures because this is not research backed. So I do not have any sort of association with genomics, even though I send huge number of samples, but I do not have any financial disclosures. But if you ask me, then we have to respect certain patented products. If we expect the results of other things will work for us, sadly it doesn't, because many companies, they're just giving you false reports. They tell you that whether it is receptive or pre-receptive. Now, what do you mean by pre-receptive? You think that, okay, it is 12 hours, so you put it. And that is where it is not working. Patient is wasting 35,000 and it is not working also. Now, last, I would just like, I had missed one point, madam, and I would, it is very important to understand. There are 2-3 things, please understand about this. When you collect the endometrial sample, with the biopsy with which you are collecting, please make sure that you don't take the entire sample. You just need little bit of tissue. What is happening is those vials, they contain mRNA solution. When you put loads and loads of endometrium in that, it is not able to lyse that tissue. And that is where you get problem. You just need to collect basic little bit of sample. Second, while doing ERA, there is no need to, do a DNC. You just need to rotate it 2 times and whatever sample comes, just send it. Trust me, you will get the report. Third and very important, after you do that test, it is very important to shake that vial. People don't do it. They just do it and they give it to nurse and nurse puts it in refrigerator. It is important that take that vial, put it on your hand, shake it for 15 seconds, make sure that the sample is mixed with the tissue. Fourth and very important, the minimum requirement for refrigeration of that sample is 4 hours. And many a time what happens, we check the ERA, we are very curious, the company person comes in the afternoon, they pick up the sample and go. Please don't do that. Make sure that you keep it. Let it stay with you for a day or 2. It does not make any difference. You can keep that sample easily for 7 days without affecting your results. So remember, don't transfer same day to the company personnel. Fourth and extremely important, I have had close to 50 patients once in one summer where all the tests came non-receptive. And then when we went into it, it was not our fault. But what had happened, it was a terrible summer, and in the transport, there were problems. So whenever you are doing this sampling during summer, please be cautious that sometimes if you get that report, sometimes there could be logistical chain issues. So do establish. Now, majority good companies are not having, but because you have raised the question of multiple companies, I really doubt whether their transport chains are good, because if they are not, you are going to get a wrong report. So these are the few things I would like to add because I had forgotten about them.
Yeah. So one more thing, sir. I mean, when is it that you start thinking of doing an ERA? So we usually give a lot of importance to the embryo and we start thinking of PGTA and all this. So do you keep it as like 2 IVF failures or 3 embryo
Yes.
failures or 2
So-
embryo failures?
So what happened was, when I started checking on ERA, I was so amazed by the result. And what usually happens to a young doctor like me, I was so much in love with that ERA that I started recommending to everybody. So much so that I did close to 150 patients in first year itself. And then what happened is, then I started checking the results. And I actually found that close to 76 to 78% patients of our Indian profile, they do have a receptive endometrium. God is kind to us. That is how we get so many positive patients. So then I started checking, okay, which of our subsets are facing these problems. And those are the indications which I have shared with you. Young patients, if you are very young patient, 21, 22, 23, although these are rare, think about transferring in patients, because those patients are, on one side, they are super confident that they are young, they have to conceive. So if they don't, they will not come back to you. They will think that you have done some mistake. For young patients, rather than being super confident, advise them around. Extremely young age, I'm saying. Again, the another extremes of age group where above 40, these patients tend to have displacement. Second and extremely important criteria I shared with you was premature ovarian insufficient failure, where your age and AMH is not matching at all. In such implantations can be hampered. I'll tell you, extremely low age OMH patients in young, you will find that Mullerian anomalies are very common in them. Now, just like Mullerian anomalies are very common in them, similarly, their genetic expression of endometrium is also different. So for these patients, think about doing ERA. For grade 4 endometriosis, transferring good quality embryos many a times doesn't work because they tend to have displacement. So in my clinical practice, if such criteria patients they come, then I tell them about endometrial receptivity before I do the first transfer. I tell them that you fall into that category where I've done many ERAs and I've come to a conclusion that you may be one of those, but you don't need ERA right now. Let me transfer once. If cycle doesn't work, you should be aware. What happens is, if you don't talk about it at the outset, after one transfer, if you talk about it, the same patient will somehow you. Why the hell you didn't do it in the beginning itself? So it is your duty to tell them in the beginning that you are probably among those patients who could have displacement, yet we are going to take a chance. And if that patient demands, no, you do ERA, you do it. What's your problem? This is how I do it, so they don't fight with you. They know that there is one remedy. Many times, because of this kind of discussion, I have seen that the moment cycle happens negative, patient only tells me, doctor, wo ERA humne kiya nahi, wo ek kar lenge. So it really helps. You have to do it. And last financial tip which I want to all of you give is, many centers who are doing less number of ERA tests, you will often find that Igenomics, especially Igenomics company, will obtain 4,000 rupee charge from you for that customs, for that transfer logistics. They will put it in their bill. Now, what you have to do is, if you are having multiple patients for endometriality, make sure that you will send all samples at one time. So collect for that week, send it on one, and tell them I am going to 4,000 only for one patient. For rest of the patient, you have to deduct 4,000 rupees. They will not show you in different bill, but fact is those 4,000 can be deducted from rest of the patient's charges, if you are clever enough to send all the samples at once, rather than sending one on Monday, one on Wednesday, and one on Saturday. Send it at once so that you will save good amount of money.
Yeah. So that was a beautiful presentation, sir. Thank you very much. Thank you for your time.
Thank you.
Thank you, Mahesh, for your presentation. It was really very, very informative. So I thank all the participants. Dr. J has sent his apologies. He has an emergency in the hospital. and it's already 9:34. So I thought I will do the presentation, but I think we are all like tired on a Saturday evening. I think all of you deserve a good sleep and a good weekend for tomorrow. Thank you very much, everyone.
Thank you. Thank
Yes.
you. Thank you.
Thank you.
Arun?
Good night.
Yeah, good night, sir.
Good night.
Good night.